Welcome to Healing Horizons. I'm Chris Daniels, your host, and today we're unpacking Ibogaine therapy alongside other alternative treatments for addiction and PTSD. My goal is a clear, compassionate comparison. How these approaches work, who they may help, what the safety essentials are, and how to choose a path that fits your life. We'll spotlight best practices in Mexico, where much modern Ibogaine care occurs, and we'll ground everything in science, experience, and practical next steps. This is an educational conversation, not medical advice. Take notes, bring questions to your clinician, and let's navigate options with realism, rigor, and hope. Ibogaine is a psychoactive alkaloid from Tabernanthe iboga, a shrub used in West Central African spiritual healing. In contemporary settings, especially in Mexico, clinicians have adapted Ibogaine for addiction interruption and trauma processing. People consider it because many report rapid opioid withdrawal relief, reduced cravings, and meaningful psychological insights that can catalyze change. Mexico has become a hub due to permissive regulations and experienced providers, drawing international clients who cannot access Ibogaine at home. Still, it is not a magic bullet. It is an intense, medically sensitive intervention that must be delivered with caution, preparation, and a strong aftercare plan. How does Ibogaine work? Several mechanisms likely converge. First, many opioid users experience a rapid interruption of acute withdrawal, sometimes within hours, which can open a window for change. Second, Ibogaine is on-irogenic, producing extended, dreamlike imagery that helps some people revisit patterns, memories, and emotions with new perspective. Third, its metabolite norbogaine lingers for days to weeks, modestly elevating mood and tempering cravings in some individuals. Neurobiologically, Ibogaine touches multiple systems: NMDA, kappa opioid, sigma, nicotinic acetylcholine, rather than a single receptor. That breadth may explain simultaneous physical and psychological effects, while also reinforcing the need for careful medical oversight throughout. What does the evidence say? We have observational studies, case series, and registries suggesting Ibogaine can reduce opioid withdrawal severity, cravings, and use, with some benefits for mood and trauma symptoms. Outcomes vary widely. Randomized controlled trials are limited, and long-term follow-up is uneven. Most apparent successes pair Ibogaine with diligent aftercare, including therapy, recovery supports, and contingency planning. Relapse risk remains real, particularly without structure. Safety signals are also real, underscoring the need for medical screening and monitoring. Bottom line, promising but incomplete evidence, requiring informed consent, realistic expectations, and a commitment to sustained behavior change afterward. Safety must come first. Appropriate programs require thorough medical pre-screening, history and physical, 12-lead ECG to assess QT interval, electrolytes including potassium and magnesium, liver function tests, complete blood count, and, when indicated, cardiac echo or stress testing. A pharmacist or physician should review all medications and supplements for interactions. During dosing, continuous cardiac and pulse oximetry monitoring are standard, with frequent vital signs and readiness to correct electrolytes. The facility should have advanced cardiac life support, a stocked crash cart, oxygen, defibrillator, and clear transfer agreements with a nearby hospital. Protocols matter because timing can matter greatly. Key contraindications include structural heart disease, prolonged baseline QT interval, a recent heart attack, uncontrolled hypertension, serious arrhythmias, and severe liver disease. Significant electrolyte disturbances must be corrected before any consideration of treatment. Drug interactions are critical. Methadone and many QT-prolonging medications increase risk. Certain antidepressants and antipsychotics can compound cardiac load. Stimulants elevate sympathetic stress. Some antibiotics and antifungals also extend QT. Recent cocaine, heavy alcohol, or benzodiazepine dependence complicate safety and may require stabilization first. Honest disclosure is life-saving. If a clinic downplays risks or rushes screening, that is a red flag. Walk away and reassess carefully. Mexico's legal landscape allows Ibogaine in clinical settings, but national standards and enforcement are uneven. Excellent teams exist, and so do risky operators. Vet providers carefully. Ask, who is the medical director and what are their credentials? What is the screening protocol and exclusion criteria? Is there 24/7 bedside monitoring with telemetry and ACLS-trained staff? Is a crash cart present and checked? What hospital is the transfer partner and how fast is transport? How is dosing determined? What is the integration plan and follow-up schedule? Request references, outcome data, and proof of insurance before committing financially. Let's compare with ketamine. Ketamine shines for rapid relief of depression, suicidality, and sometimes PTSD symptoms, usually delivered as a series of infusions or lozenges with psychotherapy. It does not interrupt opioid withdrawal the way Ibogaine can. For someone in urgent opioid detox, Ibogaine may offer unique leverage. For primary mood or trauma symptoms, ketamine can be safer medically and more accessible. Durability differs. Some maintain ketamine gains with maintenance sessions, while Ibogaine often aims for a single flood dose plus boosters only when indicated. Both require integration, sleep hygiene, nutrition, and community to convert neuroplasticity into behavior change sustainably. Psilocybin and ayahuasca emphasize insight, emotional processing, and spiritual connection. They do not provide acute opioid detox. Ayahuasca includes MAOIs, creating significant dietary and medication interactions, and can be hazardous with certain antidepressants, stimulants, or sympathomimetics. Psilocybin has fewer pharmacologic interactions but still demands screening, preparation, and integration. For alcohol or benzodiazepine dependence, none of these should replace medically supervised tapering or stabilization, which can be life-saving. People sometimes pursue psilocybin or ayahuasca for entrenched patterns after stabilization, whereas Ibogaine may be chosen to disrupt withdrawal and cravings first, then followed by insight-oriented work as appropriate and safe later. MDMA-assisted therapy is showing strong results for PTSD when delivered in a structured therapy-intensive model. Its mechanism enhances fear extinction and emotional processing with reduced defensiveness. It does not treat opioid withdrawal. Cardiovascular screening still matters with MDMA, though risk profiles differ from Ibogaine. Legal access is evolving through expanded access sites and research programs in some countries, while broader approvals remain pending in many places. For someone whose primary concern is chronic PTSD without active substance use disorder, MDMA-assisted therapy, or EMDR, may be a better first step, reserving Ibogaine for detox-focused needs or later. Do not overlook non-drug therapies. EMDR can target traumatic memories efficiently, often within 8 to 12 sessions for focused cases, and integrates well with addiction counseling. Somatic approaches like sensory-motor psychotherapy and breathwork help regulate arousal and rebuild interoceptive safety. Cognitive behavioral and contingency management remain core for substance use care. For depression or PTSD, transcranial magnetic stimulation may help after medication trials, delivered over 4 to 6 weeks. These options can be combined before, after, or instead of psychedelic-assisted care. They are accessible, repeatable, and safer for many medical profiles, especially when cardiac risk is present. Where do NAD plus infusions and similar biological supports fit? Some patients report eased withdrawal or improved energy with intravenous NAD plus, amino acids, or micronutrient protocols. Evidence remains preliminary, with small, uncontrolled studies and mixed outcomes. These modalities can complement medical detox and early recovery but rarely replace them. Be cautious with sweeping claims. Costs can be high, protocols vary widely, and quality control matters. If used, integrate them within a coherent plan that includes counseling, sleep, nutrition, exercise, and relapse prevention work. Track objective outcomes like withdrawal scales, craving ratings, and function, rather than relying on impressions alone. How does Ibogaine relate to conventional medications for opioid use disorder? Buprenorphine and methadone reduce mortality, illegal opioid use, and infectious risks. Naltrexone can help selected patients after detox. These are gold standard harm reduction tools. Ibogaine is not a replacement. For some, Ibogaine can catalyze a transition off full agonists or interrupt chaotic use, but many still choose long-term buprenorphine or methadone afterward, and that is success. The safest treatment is the one you can access, tolerate, and continue. If you are at overdose risk, seek Miljud now. Do not delay life-saving care while researching alternatives at all. Who fits Ibogaine? People seeking rapid opioid detox who can pass medical screening and commit to structured aftercare. Who is better served elsewhere? Those with primary PTSD or depression without active substance use may start with MDMA-assisted therapy, EMDR, or ketamine. People with cardiac risks should avoid Ibogaine. Integration drives outcomes. Plan 8 to 12 weeks of therapy, recovery meetings, sleep normalization, nutrition, physical activity, and craving management skills. Decision path. Weigh urgency of detox, medical suitability, access to high-standard care, your support system, and preference for therapy. Intensive versus medication-intensive routes. Then choose the safest option. 2 brief stories. First, a 36-year-old on high-dose fentanyl completed medically supervised Ibogaine, experienced minimal withdrawal, then followed 12 weeks of EMDR, recovery coaching, and sleep training. 1 year later, she maintains employment and sobriety with ongoing therapy. Second, a veteran pursued Ibogaine without integration, felt clear for weeks, then relapsed under stress. He returned months later, built a support network, and now pairs therapy with medication, reporting steady progress. Takeaway: preparation and aftercare decide trajectories. This episode is educational only. Consult professionals. I'm Chris Daniels. Thanks for listening to Healing Horizons. Be safe, be encouraged.